Probably the biggest story of 2024 might be the Change Cyberattack, where basically Change Healthcare was compromised, claims stopped. I can't remember how many millions of Americans and patients' personal information was compromised. Hey there, Rafi Salazar with Rehab U Practice Solutions, and this week on the show, we are taking a look, a deep dive, if you would, into 2024, a year in review. I really wanted to highlight, you're going to get different lists depending on who you're talking to, but these, in my mind, are the 10 biggest topics, news stories, and kind of future trends thinking into 2025 as we think back about the healthcare industry, the innovation, patient care over the last 12 months, some of the big things that have affected it or have changed it, and then some of the topics and issues to keep an eye on as we start the new year in, at this point, just a couple of weeks. The time of this recording is middle of December, give or take. We've got, a week and a half, 2 weeks until Christmas, and some of us are going to be off and gone for the holidays. So I figured before we just cut off for 2024, we do a little year-end review for the show. So that's what we're going to do in this episode. I'm just going to go through the list. There's 10 topics or 10 items. I'm going to go through the list, and then I'll kind of dive into each one. So the top, we'll say the 2024 year in review, the healthcare industry highlights, and maybe even some anecdotes. So the first one, probably, at least in my mind, because I own a private practice, I work a lot with healthcare technology companies and software companies as they're going to market. I have a lot of colleagues that own practices, private practices, and deal with the billing and the RCM. Probably the biggest story of 2024 might be the Change Cyberattack, where basically Change Healthcare was compromised, claims stopped. I can't remember how many millions of Americans and patients' personal information was compromised. So that's topic number one, was kind of just cybersecurity, specifically the Change Healthcare attack. Number two was just the idea of artificial intelligence and the expansion of it and the role that artificial intelligence has begun to play more in direct patient care. So for example, access to mental health, triaging, clinical decision-making aids, all that kind of thing. Number three, the financial sustainability and just sustainability of these organizations into the future and what it means for consolidation, what it means for independent healthcare remaining independent. Specifically, there was a study that came out, or an audit that came out, that showed that around 700 hospitals in the United States, many of them in rural areas, face foreclosure or just financial solubility due to rising labor costs, declining reimbursement, and patient volume issues. So the financial health of the healthcare system, if you would. Number four, virtual healthcare, just the topic of virtual healthcare in general in the United States. So again, it's gaining traction, all of that. I'll talk a little bit about that in the next little bit. Antitrust, specifically as it relates, so number five is antitrust, specifically as it relates to information systems, interoperability, software platforms, EMRs in particular, and I'm thinking right now of the Epic antitrust lawsuit. Number six, health equity, the focus on health equity in the United States and health equity innovations. And then number seven, interoperability as a topic. So the ability to exchange data in between sources, between health systems or entities. Number eight, advancements in the devices for musculoskeletal health. So using devices that have been FDA approved and what that's done for healthcare, specifically on the musculoskeletal side. Number nine, leadership challenges in the industry of healthcare. And then obviously the big news story that, as of this recording, again, just a couple weeks ago, maybe a week ago at this point, the shooting and killing of United Healthcare their insurance CEO. We'll talk a little bit about that and kind of what that means as far as policy changes and all of that. And then just the big shift coming. Number 10, the big healthcare policy shift that is foreseen anyways in I don't want to get into politics, but there was an election in 2024 that resulted in a different party getting elected and having, the House, the Senate, and the presidency into 2025, control of those branches of government, and then what that means for healthcare policy going forward, because there was going to be a drastic shift, at least purportedly, in the campaigns were alluded to, based off of the candidate, the party, and what that meant for their priorities as far as cutting spending and things like that. So let's dive right in to topic number 1, which is cybersecurity, specifically the Change Healthcare attack, or the cyber attack that happened, early on, maybe February, March of 2024. And for those of you who were living under a rock, basically Change Healthcare, which is the big clearinghouse that's owned by United Health Group, that at one point in time was processing 50% or more of all the medical claims in the United States. In maybe mid to late February of 2024, was compromised from a cybersecurity standpoint, where somebody ended up getting access to their systems, ended up encrypting and stealing a whole bunch of data, patient-sensitive data, holding it for ransom for a long time. I think Change at one point spent something like $28 or $30 million, paid it to the entity that was claiming responsibility. They still didn't get their data back. They had to rebuild a lot of their systems from scratch. So there's two main topics, or two main areas that this particular story affects. The first one obviously is the idea of patient data and safety around just security around the data that is pushed through all of these organizations, right? There's more scrutiny on that. The other thing, though, was the way that it highlighted some of the weaknesses in the healthcare systems, like the provider organizations' operations. So let's talk about the first one, is just the data. So I think a lot of times, especially in the private healthcare sector, where you're not a giant like private practice, independent clinics, things like that, we kind of get insulated from this idea. We don't really think about cybersecurity as a whole. Maybe we pay for a firewall. Maybe we have some consultants come in every now and then and tell us, best practices. Maybe we do training every year. But the cyber attack on Change Healthcare really highlighted two things for me in particular. One was that obviously this data is very, very valuable. We know that. But the lengths to which and the capabilities that some of these nefarious actors have in gaining access to systems. So the big one here, I think it broke out in the story, and I don't have the citation or the reference. You can Google it. But at one point in time, and I think this was still confirmed as the underlying reason for the breach, was that, or at least it was being attributed as a contributing factor for the breach, was that the employee whose credentials were compromised didn't have two-factor authentication or multi-factor authentication set up on their system, and that's what allowed the criminals access to the system and to lock people out and do what they did, which is funny because it's something that we take, I think, for granted. Again, in private practice therapy, we don't, or in therapy and practice in healthcare, we don't really think about it all that much because we think we're not one of the big ones, right? Like, oh, cyber criminals are after hospital systems, insurance companies. What do we have? But the reality is, all of this data is valuable, and the people that have nefarious intent know that. So in my mind, for sure, I started advising clients to do this. I started talking with colleagues and was like, listen, this is something you need to get in order. And that was making sure that you're following best practices from a cybersecurity standpoint in your healthcare business, regardless of the size. If you don't have multi-factor authentication set up, you need to. If you're not dealing with encrypted networks, you should be. If you don't have like a firewall in place, at bare minimum, you should. And then, there are organizations now, IT companies, cybersecurity consulting firms that you can pay them. I don't know how much. I'm sure it's well worth the investment, but they'll do a random audit of your system at random times. They'll try to access it. They'll maybe try to send a phishing email. They'll try to access break through your firewall or something like that, and then they give you a report. Say, we on this date at this time we tried to access your system and it was a no-go. That's good. You keep on the good work. Or we were able to access the system. This was the deficiency. This is the training you need to provide, or this is the system you need to put in place. This is what you need to change so that it doesn't happen again. And it's always good to have something like that almost on autopilot, because the reality is, as healthcare leaders, as healthcare business owners, we've got a lot on our plates, right? And I don't have the time. I know I don't have the time to keep up with the latest cybersecurity, advancements and attacks and threats and all of that. So it's nice to have somebody in your back pocket, if you would, that's kind of doing that for you and making sure that you are just doing the most that you can, your due diligence, if you would, to protect and safeguard the information for the patients that you hold, because the compromising it can be very costly for those individuals and for yourself as an organization, right? The other piece of this cybersecurity attack really just highlighted in a lot of ways, and we'll get to this in a little bit, the financial thin ice that a lot of providers find themselves in the U.S. healthcare system. I know there were times during, I think it took, by the end of the cyber attack, I think it took ultimately 3 to 6 months maybe for things to quote unquote get back to normal from a claims processing standpoint for a lot of organizations. And there were many healthcare providers, big ones, small ones, medium-sized ones, that were going to the government and saying, listen, we don't have money to provide these services because the spigot got turned off. And the way healthcare works from an RCM standpoint, a revenue cycle management standpoint, is a lot of times you're paying out, well, most of the time you're paying to provide the service as a healthcare organization. You're paying overhead, you're paying clinicians to do their job, you're paying whatever. The costs of doing healthcare, providing the healthcare service, happen and are incurred before you receive payment. Sometimes you don't receive payment for 30 to 45 days. So the reality is, especially in private practice healthcare, where you don't have very large financial reserves, there were providers that I knew that shut down their doors because the reality was they had 30 days worth of money in the bank, if you would, and they weren't able to process claim for 60 days, so they were using lines of credit. Some of them actually closed their clinics because they just simply couldn't afford to pay people and continue to provide services while they waited for the money to come in, because they were not able to file claims, which meant there was an additional delay on top of the 30 to 45 days that they were going to wait to fully collect on those visits or those services. So it really, at least in my circle, and I remember I did an interview with Paul Singh from Strata PT maybe 2 or 3 weeks after the Change Healthcare incident occurred, and we were talking specifically about this idea of understanding the financial chokeholds or financial choke points, the cash flow choke points in the healthcare business, in order to kind of mitigate those. And one of the big ones was having enough of a financial reserve, number one, but then two, understanding the impact of delayed claim processing in when that money begins coming in. So anyways, we'll talk about more of the financial footing of some of these organizations later, but I know for a fact, Optum, for example, acquired a couple health systems as a way to quote unquote save them or maintain their viability during this time, which was kind of ironic, right? One branch of their company, Change Healthcare, goes under because of a cybersecurity incident. So this independent healthcare provider is now no longer able to file claims. It's putting a financial strain on them. And then Optum, which is another branch of United Healthcare Group, buys them in order to save them, right, and keep them viable. So it's like, obviously this was not nefarious or anything. It's just ironic the way it worked out. You had one company that's kind of like responsible for this provider organization's challenge, financial cash flow challenges, and then another branch of this company ends up saving them by buying them and adding them into the fold. And I know we'll talk about it in a little bit, but the idea of like consolidation in healthcare and what that means for independent healthcare private practices, for patient care and the like, it was just ironic. And I think it raised some questions in the proceedings that followed after the attack. Like, should we be allowing organizations to continue to consolidate, and what that means for care going forward, and the ability to negotiate pricing and all of that. So obviously, I think that the cybersecurity attack at Change Healthcare is probably one of the biggest, if not the biggest, story for 2024 as far as healthcare goes. So there's that. Number two was just the expansion of artificial intelligence into healthcare in general. So AI has played kind of a transformative role in healthcare, particularly like in surgical operations these days, mental health, and then like chronic injury management or chronic condition management. I know that we covered this, maybe it was this year. I did a podcast episode. I did an episode on specifically the idea of healthcare technology and the ROI or lack thereof in the healthcare space. And then I did another one on the research around healthcare technology's effectiveness. And I think in the research one, I discussed a good bit of studies that were being completed specifically around like AI-guided healthcare channels and pathways for individuals with chronic pain and chronic musculoskeletal pain. And one of the big systematic reviews that was published in 2024 specifically around using digital healthcare, an AI-driven digital healthcare protocol or platform or treatment model was found to be clinically insignificant difference between that and standard care, which some people say, that means it's not effective. No, it means that it provides similar outcomes, which makes you really question kind of what is artificial intelligence role going to be going forward. I know that there's been AI-assisted surgeries that kind of have been shown to reduce complications and kind of improve recovery times. And there's AI mental health tools that have made therapy more accessible to individuals. But in chronic care, that's always been the challenge, right, in healthcare. Is like, what do we do with these people who have conditions that we know are going to require treatment more than just like a set treatment time? It's not like you're just going to go to physical therapy for 12 weeks and you're going to have a recovery and then you'll be back to normal. It's like, no, people that have chronic conditions have issues that require management into the future for presumably indefinitely, right? Maybe something happens and they can go into a remission or something like that. Maybe you can reverse like diabetes or something like that. But for the most part, there's going to be a long-term management for these individuals. And at what point is the utilization of skilled clinicians no longer necessary or warranted because of some of the advancements of artificial intelligence, right? Wearable devices with AI-enabled monitoring, for example, might be able to not replace, but take some of the load off of clinicians. Because one of the big challenges, and I've said this before, with healthcare, especially in recent years where there have been clinicians leaving the professions, all professions, nursing, doctors, physical and occupational therapy, all of the healthcare professions are seeing this decrease in professionals actually practicing and the students going into the field. I sit on the National Board for Occupational Therapy, so NBCOT. And one of the things that we have been talking about over the last year in our meetings has been this trend of declining applications to health profession programs year over year. And it happened in nursing. It's happened in the ancillary healthcare, the allied health, physical, occupational, speech therapists, and it's happened at the medical schools as well. We need to do something in healthcare. One, to make sure that we're not making healthcare such a terrible or perceivably terrible career that people don't want to apply, or that's causing burnout and causing people to leave. But that's another issue. But that is going to do something to alleviate the pressure on those that are still practicing and that are coming into the field. Because the reality is, especially in the United States, we've got this aging population, which means, presumably, over time, over the next 10, 15, 20 years, there's going to be an increased demand in services, in healthcare services. Just as we age, you get more medical complications, and that's going to mean the need for more services. With either a fixed or a small growing number of clinicians that's not keeping up with the demand, there will need to be implementation of tools that alleviate the pressure that kind of multiply. I talk about it like a force multiplier, if you would. If you can take a clinician and have them manage 10 patients in the amount of time that it would normally take them to manage one, because you're leveraging some of these tools, that's a good thing, as long as we're maintaining that, again, that human connection, the accessibility to a clinician. And I know I've said this before, but technology, in my mind, when I think about it, is going to allow us as clinicians and as providers and healthcare organizations to deliver a more individualized patient experience and treatment plan with less clinician time than it would have taken before. And that in and of itself is going to be something really to look forward to into 2025. So artificial intelligence expansion, obviously the technology itself has advanced, which is great, and is being applied in healthcare, and then looking forward into ways that it can be used not to replace clinicians, because nothing will replace a clinician, but aid and give them, make them more effective with the time that they have with each patient. Number 3, and maybe this should have gone after the Change Healthcare issue, but hospital closures and financial struggle of healthcare organizations. Again, there's some big audit that was done. Maybe this broke mid-2024, but there was a report that said something like 700 hospitals, most of them in rural areas, faced some kind of foreclosure, financial hardship, or bankruptcy. And the reasons they cited in this study, or in this report, were rising labor costs causing a increased overhead or like a financial burden in maintaining the organization, declining reimbursements, and then issues with patient volumes. But that highlights the fact that I think a lot of times in healthcare, or maybe if you're outside of healthcare, there's this idea that these hospitals are making millions and millions of dollars, and they're squeezing money out of all their patients. They're just billing, they're nickeling and diming. But if you look at the actual financial performance of a lot of these organizations, you can say it's mismanagement, and there probably is some mismanagement going on. Some of it is incentive and policy regulation related, but there are not as many, not as much profit in there as you would think. It's not like these hospitals are running on 30% profit margins. A lot of them are like single digits. And because of the way, again, that I've kind of alluded to earlier, the way that the cash flow cycle in healthcare works, there's a lot of outlay of capital and money before you get paid for the services that you render. So what it means, and this has trickle-down effects all over, is that if there's an economic issue like we had in 2024, where inflation was getting high, there were some layoffs, there was concern about the economic status in the United States, or the economic situation in the United States, and people had to decide between paying their credit card, paying for gas and groceries to get to work and to feed their family, or paying their hospital bill. The hospital bill was going lower and lower on the list. So there's that piece as well, in that you're not collecting for a visit fully up front. You're not collecting for the services fully up front. You're billing the insurance company. You're getting that ERA or the response back. Then you have to send the patient their responsibility. And there are a lot of organizations that collect up front, but a lot don't. And there's just things that happen. Maybe there's a denial and now it's the patient's responsibility or something like that. So there's all this money that is owed to these organizations that is in the hand of patients. And, patients, everybody was hit. Everybody's struggling financially. So there's that delay in payment. And then there's the delay of payment that just happens from normal processing, right? You submit your claim, 30 to 45 days later, you're getting that money, which means you've already paid the doctors or the clinicians, you've paid for the software, you've paid for the building, you've paid for the malpractice insurance, you've paid for the utilities and the lights, and then you're hoping you get enough money to cover it later, right? So that in and of itself means that I heard it one time. I was talking to a friend of mine who's a consultant in healthcare as well, and he works primarily in healthcare turnarounds. And he said, well, if you look at it, healthcare is a cash flow negative business, which means you're putting out money before you get paid any money, which means as an organization, there are things you need to put in place to make sure that you have the cushion to float operations in the time while you're waiting for that reimbursement. We should just call it payment in healthcare. That's my side note. It's not reimbursing. You're paying for the services you're receiving. It's just delayed. So there's, in my mind, the way we look at it is you're essentially, as a healthcare provider, acting as a financier for your patients and the insurance company. And something needs to change about that. We don't know what it's going to be in the future. But there's that, right? So there is the outlay of capital that happens before you're receiving payment for the services you've already delivered. So there's that first piece of the financial struggle. The second piece is this idea of the rising labor costs adding to that because people are leaving healthcare and there's a lack of ability to recruit, retain clinicians. It's causing an increased demand in labor, and that means increased costs, right? And that's just putting more financial pressure on the institutions. And then on top of that, you have declining reimbursements. Now, part of this, I mentioned it in the book, Better Outcomes, A Guide to Humanizing Healthcare, but a big part of this is the fact that in the United States, we are primarily operating on a fee-for-service model, which means healthcare providers get paid for their time or for the codes that they bill, the number of codes they bill, which are a lot of them are directly related to the amount of time spent with clinicians or with patients, which means it sets up this incentive system in healthcare where the provider organization is incentivized to bill as many units as possible in the smallest amount of time in order to maximize their revenue. That's not nefarious. It's just the incentives, the economic incentives. On the flip side, when you have an insurance payer, maybe even if it's Medicare or a private insurance company like Anthem, Blue Cross Blue Shield, or Humana, when they're looking at trying to balance their books and their profits and manage their business, the only real way they have to decrease their costs are twofold. One, they can deny services or pay for less services, which means that they're going to end up in a situation where they're getting called, potentially getting called before Congress and having probes and inquiries done, investigations done as to why they're denying services, or they're going to have upset customers and beneficiaries who might look for other vendors or providers to do that for them, to provide their health insurance. So they're trying to balance that. And on the other side, what they can do is they can decrease the amount they reimburse, they pay for each of those services. And they're trying to do that in a way that doesn't push providers out of their network. So they're balancing this, they're walking this tightrope between how much do we need to pay for? Like, do we need to just not cover this service, or do we need to pay providers less for this service? And the reality, like I have said multiple times, in a fee-for-service model, you can't, out of one side of your mouth, say that you want healthcare to be affordable as a healthcare provider. I want healthcare to be affordable. We need access to everybody, but yet not be willing to take less money. So there is that as well, that providers need money to get paid, to pay their people, to maintain operations, and we're not willing to take any less than what we're already getting because the downward pressure is real, and the struggle is in actual to maintain financial solubility. But at the same time, you've got the counterparty, the people paying the primary payer in healthcare, which is at this point third-party payers, insurance companies, that are also looking at trying to maintain their financial solubility. So their way of doing that is to cover less or pay less. So there's this downward pricing pressure that happens all the time in healthcare. We hear about it every year. Medicare is going to come out in their 2025 fee schedule, and it's going to be a 4% decrease in the fee schedule. People freak out. They go back and forth. It ends up being like 1.2% or whatever. But it's a decrease nonetheless, right? And that puts financial pressure on the provider organizations. So in my mind, the way we solve this, and the way that really the only path forward in my mind that I see, is to find a way to step out of this fee-for-service model of healthcare where we move more towards value-based. Whether that value-based system is something like a shared savings incentive program. There are some organizations that do that, where there's a benchmark. I'm gonna use physical therapy as an example, just because I own a PT clinic and they come quickly off the top of my head, right? So let's say the national benchmark for a total knee replacement, the amount of visits that is nationally or done nationally is 30 visits or something. Maybe it's something crazy. And you're able to get the patient done in 15 visits. There are programs out there and some payers that are involved in this that will say, okay, you saw this patient in 15 visits, so we're going to pay you for those 15 visits, but you also saved us an additional 15 according to national benchmarks, and we're going to share with you a percentage of that savings, what we would have paid you for those. Doing things like that, programs that involve like incentivizing, like aligning everybody's incentives, can do a lot to, one, decrease that downward price pressure, because it means that there's another lever that payers can pull to save themselves money, and there's another lever that clinicians can pull in order to earn money for providing higher quality care. And it also means if you can get a patient done in 15 visits instead of 30, it means now you have the additional capacity, 50% more capacity to see another patient or another couple patients if they're less complex patients. So anyways, those are just some thoughts around the financial solubility of hospitals and healthcare organizations. And then on top of that is this idea of mergers and acquisitions becoming a survival strategy for healthcare organizations, right? I mentioned it before, but Optum bought a couple hospital systems and practices during the Change Healthcare incident as a way to save them. And then the question is it a good thing? And I did a podcast on this recently, an episode on this, which we'll link to the show notes, I think the title of that episode was, Is Big Healthcare a Problem? And the reality is that regardless of your feelings about it, healthcare is a large market, right? It's multi-billions of dollars, which means that organizations that thrive tend to grow and grow and grow. It's just a nature of the beast. So the question is, at what point is it a net negative to society and to the end user, the beneficiary of the services, which are healthcare patients, to have these organizations continue to grow and to purchase each other or their competitors and consolidate? And there's one side of the argument that says it's a net positive because it means all the systems are integrated. And there's another that says, well, you're taking away choice, you're taking away pricing pressure and negotiation abilities, because if you've got only one provider in a metro area, for example, they get to set the prices. So there's positives and negatives there, but it's something that, again, going into 2025 and beyond is going to be something that's going to be highlighted, I'm sure, from a policy standpoint. Number 4 is virtual healthcare in the United States. Virtual healthcare continues to gain traction. Obviously, telehealth is going away, they say, in 2025 unless Congress does something. But things like remote therapeutic monitoring, virtual first or AI-powered digital care models are being implemented to kind of offset some of this. We'll kind of see how it plays into 2025. My personal thought is that it might not be this in the first quarter of 2025, but sometime in 2025, telehealth is going to be reinstituted in Medicare. It's just got to be. They let the genie out of the bottle. They open Pandora's box. Whatever metaphor you want to use, it's going to be hard to put it back. So there's that. In the topic of like interoperability and stuff like that, you've got the Epic system antitrust lawsuit, which basically, for those who haven't heard, as of October of 2024, so just a couple months ago, Epic Systems, which is a big EMR, right? They're in all the major hospitals. They almost have a monopoly, right, in the hospital EMR system. They're facing an ongoing antitrust lawsuit filed by Particle Health, which is a health data company. And the lawsuit basically alleges that Epic is using its market dominance to stifle competition in the payer platform market. And there was a recent dispute between the two companies regarding patient data access, and it was resolved through I think there's something called care quality or something like that. Anyways, both parties accepted the resolution, but the antitrust lawsuit is still pending in court. So basically, Particle Health was saying that Epic was keeping they were preventing competitors from getting access to their data in order to process claims and things like that. And it is something to keep an eye on for sure going into 2025. I work with a lot of healthcare technology companies, and one of the big challenges that we have, that a lot of my clients have, is like, how do we access patient data? How do we share the data between systems? And there's always been this almost like a closed wall, if you would. One EMR doesn't want to open up its doors to another. Part of that might be security related, obviously cybersecurity being a big deal. But the reality is that all of these providers, these EMR providers, know that the data that they have is valuable, and it provides a competitive edge, because being able to integrate with them means, they're losing out on potentially another line of business. If this EMR company also has an RCM function, an RCM branch, and they open up their systems and they allow data to leave, then it means that now there's going to be somebody competing with their RCM product or something like that. So it's going to be something to watch going forward. I know that one of the big challenges in bringing some of these technologies to market is the interoperability questions. So going into 2025, it's something that I'm going to be very interested in seeing what unfolds, either from a policy standpoint, from lawsuits like this, or just from kind of the free market and organizations creating tools and APIs and systems that safely and securely allow data transfers. So number 6 was this idea of health equity, kind of how it's taking a step into the forefront, specifically around health disparities in different geographic locations. For example, in those 700 hospitals that are struggling financially, a large number of them are in rural areas. So the idea of health equity and making sure that everybody has access to quality care is going to be something that's going to be the highlight, I think, in going into 25, 26. And I know we had Soda Health on the show a while back, Josie Baker from them. We had Equity Quotient with Perfecto Sanchez was on the podcast this year, talking specifically about all these factors, these social determinants of health, factors that you wouldn't think affect the quality of care, your healthcare outcomes, like your zip code, but they do in the United States. And I think there's going to be more and more of a push towards trying to normalize that across geographic and socioeconomic bounds. So that's going to be something to look forward to in 2025. Again, number 7 was interoperability, kind of touched on that a little bit. Number 8, advancements in devices for musculoskeletal health. So FDA approved neuromodulation devices, for an example, and wearable technologies have been used in 2024 to advance musculoskeletal care. These devices, they kind of offer non-invasive pain relief, right? Real-time rehabilitation guidance, the goal being like improving patient compliance and hopefully clinical outcomes. And then there's the AI-driven apps that are gaining traction and enabling tailored like physical therapy practice physical therapy plans for patients and stuff like that. One of the anecdotes or stories that I looked at in kind of researching this was that there was a high school athlete in New York who used a device, a wearable device during rehab that sped up their recovery and their return to sports. There's kind of like this little write-up piece. Maybe I'll link to it. But it just, again, highlights this idea of, one, how do we pay for it? Like this idea of fee-for-service healthcare, and how do we move more towards value-based? If you're doing value-based payments or moving in that model, then some of these things become more accessible to you, right? Because you're not worried about nickel and diming, if you would, or billing for time because you're getting outcomes, which means that there will be a quicker adoption of some of these technologies. I know I've mentioned this before, but we have a couple payers here at the clinic that pay us just a lump sum for services. They say, based off of your evaluation and this assessment, this is the amount of money that we will pay you to cover or to provide services and manage care for this patient. Do with them what you will. And we're able to then use things like remote therapeutic monitoring, some of these digital health forward tools, to provide services. And we're in the middle still of like tracking outcomes and making sure that the outcomes are adequate or comparable, if not better, than what traditional care would be. And we're able to do it in a way that's increasing our profitability, but also, I would like to think, improving the patient experience, their engagement, and their clinical outcomes. Again, we're still tracking data on it. We're going to see how it pans out over the next little bit. But I know our patients that we see that are on these healthcare plans enjoy it and appreciate being able to, like, for example, shoot a secure message to our clinicians and stuff like that. Number 9 is kind of leadership challenges in healthcare. There's a lot of CEOs and executives now, especially after the assassination of Brian Thompson, who's the CEO of United Healthcare, that are kind of in a risk mitigation plan, right? Like there's just a lot going on recently that have healthcare executives and really policymakers and everybody kind of looking at like compensation. What is compensation? How do you effectively lead? What is fair compensation? At what point are some of these leaders responsible for some of the policies that get rolled out at their organizations? Obviously, like if you're a CEO, the buck does stop with you, but some of these organizations are so big, for example, like if Optum or United Healthcare implements this policy change in the way they process or manage denials or something like that, that's made like 7 layers down, and maybe the CEO doesn't even get, maybe they get briefed on it in a quarterly meeting or something like that. Like how much do they really know what's going on? And then there's been some leadership turnover in some of the big organizations as well. So it's just something, again, I think this kind of falls into this, is big healthcare a problem? At what point do these large organizations become too large for their own good or for society's good? And how do we think about that? Because it is a challenge to manage an organization that is so big and so large that you're really, like I said, just getting briefed on some of these things in a 2-minute slide on a presentation or something like that. So anyways, that's one of the big ones. And then probably the biggest news story of 2024 was just the election. Trump got elected, but the big thing about that, and as it relates to healthcare, which is going to be something to look forward to in 2024, or not look forward to, but kind of monitor and watch into 2024, is what that change means for healthcare policy priorities going forward, right? RFK Jr. is involved now as like an advisor. He's getting appointed as like Health and Human Services Secretary. Like there's just a lot of turbulence, if you would, potential tumult going on in the healthcare industry and some of the priorities that might change, like additives in foods, and then maybe a new focus on nutrition and what it means for vaccine mandates and what it means to Medicaid expansion and funding and Medicare's ability to negotiate like drug rates and stuff like that. So I don't have a whole lot of like predictions or thoughts on this other than it is going to be something to watch and monitor as we go into 2025, because there's going to be a big change. I'm not saying whether it's going to be good or whether it's going to be bad. I've got some concerns about it. I also see some potential benefits. I think anything focusing on improving just access to education and informing, like the nutrition piece for people might have, for the population might have some benefits. But there are some concerns about what it means for access of care and stuff like that. So again, it's kind of like put a pin in it. We'll kind of watch what happens over the next little bit in 2025 and beyond. So anyways, that is kind of the year in review, kind of plan, or not plan, but the year in review, things to look for in 2025. Hopefully, if nothing else, it gave you some entertaining listening. I'll try to link to relevant articles in the show notes. You can find those at betteroutcomes.show or rehabupracticesolutions.com. Just click the drop down for podcast under Insights, and you can listen to all the episodes. If you want to sign up so that you get notified when we drop a new episode, you can do that as well at either of those websites. There's places all over to sign up and subscribe. So other than that, if you run a healthcare organization, a technology company, a startup, or a healthcare provider organization, and you are looking to differentiate yourself from the competition and create a positioning strategy that drives business in the form of qualified healthcare leads, check out the Positioning Alignment Workshop. We're not doing any more in 2024, but we're opening up our calendar into 2025. And you can find more about that at positioning.rehabupracticesolutions.com. If you want to hire me to speak at your organization or your event, we've got a page set up for that as well, speaking.rafisalazar.com. Again, not booking anything out, probably for the first little part of 2025 at this point. I know I've got a couple engagements maybe in February and March that are already booked out, but nothing after that. So you can learn more about that at speaking.rafisalazar.com. Until the next time, folks, be safe, be healthy. I will talk to you then.